Hello and welcome. My name is Dr. Brandon Bosquet. I'm a board certified podiatrist and certified wound specialist physician, and I serve as a medical science liaison at Aroa Biosurgery. Today, we're going to look at what real world data tells us in the analysis of over 2,000 diabetic foot ulcers in the United States. Now, unfortunately, we know that this is a growing and global problem with over 166 million people worldwide at risk of developing a diabetic foot ulcer, and 1 in 6 at risk of requiring a life-altering lower limb amputation. This is a big issue for our patients and their quality of life, but also presents a significant cost burden to the healthcare system, with estimates between $9 billion and $13 billion in cost burden in the United States healthcare system alone. So let's start by looking at what real world data means. Many of us are familiar with the term randomized controlled trials, or RCTs. They are rigidly designed with very strict inclusion and exclusion criteria so that variables can be minimized when determining if certain treatments are effective. This presents a unique challenge when studying chronic wounds like diabetic foot ulcers. So pioneers like Caroline Fife devised the idea of utilizing real-world data studies to augment the results of randomized controlled trials. Real-world data studies allow for larger sample sizes to be studied retrospectively and less restrictive inclusion and exclusion criteria so that patients with advanced age, uncontrolled diabetes, kidney disease, poor circulation, and cancer are not excluded from the study like they frequently are from randomized controlled trials. Why? Well, we know that in our patient population, those comorbidities are very common. So if we eliminate them from study, how can we really know if certain treatments are effective? So that inspired us to embark on the first large real-world data study that directly compares the healing outcomes head-to-head of two commonly accessible collagen-based treatments, OFM, ovine forestomach matrix, known as Endoform Natural, and collagen ORC, also known as Promogram. Let's take a look at what these two products look like compared to normal human soft tissue extracellular matrix. This chart here shows the general composition of these three components. First, we have human soft tissue extracellular matrix. This is a snapshot of the different proteins that are involved in composing our soft tissue extracellular matrix. We can see multiple types of collagen important for structure, fibronectin, elastin, hyaluronic acid for moisture retention, glycosaminoglycans, growth factors for cell signaling and chemotaxis, as well as an intact basement membrane and vascular channels. We can see here that Endoform is an intact, all-natural extracellular matrix that has all the same secondary proteins that are found in our normal human ECM with no fillers and comes from a source that is highly vascular with high cell turnover. We see that Promogran is simply just type 1 reconstituted collagen, devoid of these other secondary proteins, with 45% cellulose filler for strength, and comes from avascular bovine hide. So you might be asking yourself, well, these products are very different biologically, so why are you studying them in this trial? The reason is access. Endoform and Promogran are commonly found in outpatient wound care centers and are available on day one, regardless of who is applying the product, whether it's a provider like a physician, whether it's a nurse, whether it's the patient themselves or their family members. So while these products are very different biologically, we're studying them head to head because they have the same accessibility as collagen-based treatments on day one for diabetic foot ulcers. So let's look at the study design. We extracted data from 449 wound care centers across the United States and started with over 25,000 different wounds and etiologies. So our inclusion and exclusion criteria is less restrictive by design. We wanted to look at just diabetic foot ulcers and diabetic foot ulcers treated between 2014 and 2020. We wanted at least 2 wound care center visits because we think that any wound that was healed in one wound care center visit was probably not that challenging. And we looked at an initial size of between 1 square centimeter and 150 square centimeters, which is quite large for a foot. Being a podiatrist, I don't think I've ever seen a wound at 150 square centimeters. So we had an all-encompassing initial start in wound size. And we excluded wounds that were treated with both products because that can skew our results. We excluded patients that were under palliative care because we know the goal is not to heal these patients. They just are comfort care. And we exclude patients that were under active treatment when we extracted the data in 2020. We also excluded wounds that were devoid of any baseline data or follow-up data. but we did not exclude any patients with challenging comorbidities. What that led us to was over 1,150 wounds on 807 patients treated with Endoform Natural and 1,072 wounds on 783 patients treated with collagen ORC or Promogram. Let's look at the patient demographics. We found that the cohorts were very similar in terms of the gender of these patients, the age of our patients, and even the hemoglobin A1C. Not one cohort was better controlled with their diabetes than the other. These were statistically found to be similar between the two cohorts. Let's look at let's look at the demographics of the wound themselves. We looked at the initial wound size. We looked at the number of wounds per patient, and we looked at the chronicity or the age of the wound. Again, these two were relatively the same, but we found that the Endoform cohort actually started with a statistically significant larger wound than the collagen ORC group. But otherwise, these were very similar cohorts in terms of demographics by patient and wound. Let's look at the results. This bar graph here shows the delta or the difference between patients treated with Endoform and patients treated with Promogram in terms of the reduction in time to close in weeks. This first bar graph here is all 2,200 wounds treated in this cohort. And we found that wounds treated with Endoform were healing on average about 2 weeks sooner than in wounds treated with Promogram. As we move far along here with the different subgroups, these are patients treated with either product in 4 or greater wound care center visits, 8 or greater wound care center visits, or 12 or greater wound care center visits. So you can extrapolate that if you're being seen in the wound care center 8 or 12 times or more, these are more challenging wounds. And what we found was that the more challenging the wound, the more Endoform outperformed Promogram. We see in this subgroup right here that Endoform was healing patients on average 5.6 weeks sooner than patients treated with Promogram. We see this dip down here because we know that patients that are treated 12 weeks or greater in the wound care center have likely very challenging wounds that may have different wound healing trajectories. But even still, these that were the most challenging wounds still were healing on average 5.3 weeks sooner treated with Endoform versus collagen ORC or Promogram. And all were found to be statistically significant. Now, we also performed an analysis of probability as well. These here show both unadjusted data, raw data, and adjusted data that accounted for different demographics like the wound age or hemoglobin A1C. And we found again in all wounds in the unadjusted group, Endoform gives you an 18% increase in probability in healing compared to Promogram. When you adjust the data for different demographics and variables, up to 21% increase in the probability of healing when treating patients with Endoform versus Prisma Promogram. And as we move along the different subgroups, the most challenging patient cohort requiring 12 weeks or greater in the wound care center, Endoform gives you a 36 to 38% increase in the probability of healing compared to Prisma Promogram, either with unadjusted or adjusted data. So what does that tell us? That tells us when we look at a very large sample size of over 2,222 wounds, that Endoform on average can heal patients almost 2 weeks sooner in the entire cohort, and in the most challenging of cohorts, 5.6 weeks sooner with Endoform versus Promogram. And also with statistical analyses, we found that there's a up to 38% increase in the probability of healing when you're treating patients with diabetic foot ulcers with Endoform versus Promogram. Now, what that tells us is that we are getting patients back to their quality of life sooner, and we can unlock regenerative healing with patients if we're utilizing Endoform sooner and instead of other traditional collagen-based treatments. Thank you very much for listening, and I hope that you're able to think more critically about what real-world data means for you and your patients, and I hope that you consider utilizing Endoform as a first-line treatment on day 1 for your diabetic foot ulcers. Thanks for paying attention, and thanks for joining us today.